Hi everyone, my name is Megan Tarvis, and this is my presentation on HIV and pregnancy. So HIV is the human immunodeficiency virus, where basically when it's in the body, it attacks the body's immune system by destroying CD4 cells. Patients with low CD4 counts will be susceptible to more infections, which can lead to eventually AIDS. Transmission usually occurs within the bodily fluids, such as semen, blood, breast milk, vaginal, or rectal fluids. And there's no current cure for HIV or AIDS, but there is management of CD4 viral load. So the epidemiology prevalence, the perinatal HIV has decreased to about 41% since 2015 to 2019. So the CDC has seen an initial decrease, and they believe that decline is due to prenatal testing and antiviral therapy. In 2019, there was about 1% diagnosed with perinatal HIV, and in 2019, again, 36,801 cases in the United States. 84 of those cases were due to the perinatal transmission. And again, transmission is through unprotected intercourse, sharing IV drug needles, and accidental work needles, like sticking yourself at work, through labor, and as well as breastfeeding. There are some risks to each factor: maternal, prenatal, and fetal. Maternal, obviously, if mom has HIV, she's at risk for infection, opportunistic infections, which we'll talk about later. If they have a C-section, they're going to be slower to healing their incision. They're more at risk for AIDS, which leads to death. Prenatal risks, they're basically at risk for transmission to the fetus during delivery. And they're also fetal risks, their risks when they're born. If they contract HIV transmission, their risk for infection in their first year of life, failure to thrive, pneumonia, developmental delay, and even AIDS. Here's a diagram of patient presentation: fever, sore throat, swollen lymph nodes, rash, muscle aches, fatigue, night sweats, mouth ulcers, which I'll talk about in my next slide. So I divided them up into the 3 stages of HIV. So subjective, stage 1, you're going to have an acute infection like flu-like symptoms. They're going to feel tired, chills, fever, muscle aches, night sweats. And then the second stage is a clinical latency. So this is where they may not have any symptoms, and flu-like symptoms may increase towards the end of the stage. So they'll get those flu-like symptoms again. And then stage 3 is AIDS, where they have persistent diarrhea, fevers, night sweats, loss of memory, fatigue, depression, and neurological disorders, as well as infections. And then for objective data, a patient with stage 1, we're going to see rash, we're going to feel swollen lymph nodes, we're going to visualize ulcers in the mouth or the throat. Stage 2 is that clinical latency we talked about. It's active in the body, but there's low levels. So we'll see an HIV viral load is increased, but the CD4 count is decreased at the end of the stage. In the beginning of this clinical latency, CD4 levels aren't as decreased. And then stage 3 AIDS, the CD4 count is less than 200 cells per millimeter. We're going to see a rapid weight loss in our patients, feel swollen lymph nodes all over the body, sores in the mouth, anus, and as well as the genitals. Differential diagnosis. So a patient presents with these diagnoses, often can look like these diagnoses, but have HIV. So HSV, cytomegalovirus, influenza, toxoplasmosis, lymphoma. These different diagnoses can overlook patient with HIV. So diagnostic testing is basically a simple laboratory screening testing. It's the antigen and the antibody combination of immunoassay. It detects HIV 1 and 2. Um, Basically, if a patient comes back reactive, no further testing is required unless they're recently exposed, like they had a needle stick or a recent encounter, they may need to retest within a month. And then if they are reactive, they need to be tested to differentiate the HIV-1 antibodies from HIV-2. So the treatment plan, if they are reactive, pharmacological antiviral therapy is recommended during pregnancy to reduce HIV transmission despite the CD4 count. So patients may be taking antiviral therapy prior to pregnancy, or they may not have any. So we want to assess whether they're taking this therapy or not. So the therapy is a little complicated, and you want to make sure the patient is taking the correct medication based on their CD4 count or whether they're pregnant or not. Some medications are not safe enough. So these are the different types of preferred therapy of medications listed that are safe for pregnancy. If patients are already taking the therapy, again, assess if the medications are safe. And then IV cytoluvudine is usually given during labor before C-section. And you want to start therapy as early as possible. So as soon as they find out they're pregnant, you should be creating a treatment plan with medications for them. And then you also want to discuss their immunizations recommendation for during pregnancy, see what they have already taken. Again, influenza, tetanus should be given first trimester, or their Tdap should be given in the third, along with the COVID vaccines can be given any trimester. We know these patients are at risk for infections, so we want to make sure they're vaccinated fully. Recommended for individuals is the pneumococcal vaccine, along with Hep A and B for individuals who have not been infected with hepatitis A or B before. We know patients are at risk for hepatitis with HIV, and they're at risk for infections. So we want to make sure those two vaccines are provided during pregnancy. Non-pharmacological interventions. So there's a national perinatal HIV hotline for providers as well as patients. They can call that and receive advice, prenatal care, antepartum care, postpartum care, or preconception care. We want to obtain a prenatal laboratory panel when they go for their initial visit, assess what their CD4 count is, get a baseline chest x-ray, make sure they don't have any pneumonia or infection in their lungs, assess their plasma HIV viral load, monitor liver function, and screen for STIs. If they have HIV, they may have other sexually transmitted infections such as chlamydia, gonorrhea, tuberculosis testing as well. And like we talked about, assess their vaccination status. You want to make sure they're up to date on all their vaccines. So education, it's important to educate the patient on the severity of the virus, how important it is to prevent transmission to their baby or other individuals, such as partners, as well as taking their antiviral therapy. ACOG recommends a cesarean to lower the risk of transmission to the neonate, as well as they can have a vaginal delivery, may be considered if the patient's viral load is less than 1,000 copies, but it's up to the provider's discretion whether they think they're appropriate for a vaginal delivery if it's safe. Otherwise, they may want to schedule a C-section, usually starting at 38 weeks, to avoid a spontaneous labor, to avoid breaking their water at home or having a fast labor that eventually leads to vaginal. Things in labor that we should not recommend is artificial rupture of the membrane. We shouldn't be breaking the water during labor. We shouldn't be placing a fetal scalp electrode on the fetus head. Episiotomy or even an operative vaginal delivery, because we want to decrease that transmission. Breastfeeding, we want to counsel patients that they have patients at risk for transmission breastfeeding, so we want to encourage formula instead. And patients should continue their medication therapy for viral suppression for their own cells postpartum, or if they want to get pregnant again, they're already covered by taking the therapy and suppressing those viral load. In the fetal well-being, what we're going to do is ultrasounds patients who are taking antiviral therapy, they should receive a fetal anatomy ultrasound in the second semester to assess for fetal anomalies. Although the medication is benefits, it can produce some fetal anomalies as well as low birth weight. So I'm going to assess fetal growth weight, assess the fetal growth in the third trimester, as it can cause a low birth rate. And another question patients usually have is invasive diagnostic testing. Patients that are receiving antiviral therapy can still have invasive testing if needed. So this is often like a discussion whether a patient in amniocentesis puts them at risk for transmission. It doesn't if they're taking the antiviral therapy. And that is my presentation. Thank you for watching.